Good morning. I'm Dr. Joe Barbuto, and on behalf of the Faculty Council, I would like to welcome everyone to this Grand Rounds presentation. Today, we're fortunate to have a nationally and internationally recognized expert in sex therapy as our presenter. Dr. Michael Perelman is a clinical professor emeritus of psychiatry and former clinical professor of reproductive medicine and urology at Weill Cornell Medicine. He has directed its human sexuality program founded by Dr. Helen Kaplan for almost 30 years. That program is the longest running sex therapy conference in the world, providing continuing education for its graduates and guests. As a National Institute of Health Fellow in 1976, he wrote the first sex therapy dissertation in Columbia University's history. Dr. Perelman was the chief intern in psychology at Duke University Medical Center and then went on to receive his PhD at Columbia University. This was followed by a postdoctoral fellowship studying with Dr. Helen Kaplan here at New York Hospital. In 2012, he founded the MAP Education and Research Foundation, a public charity that emphasizes the biomedical and psychosocial and cultural approach to the diagnosis and treatment of sexual disorders, using its sexual tipping point model. The foundation grants STP awards for best abstract or presentations delivered at sexual health care professional meetings. As an international leader and member of over 25 professional associations, Dr. Perelman served on several of their boards of directors and was president of the Society for Sex Therapy and Research. He was elected a fellow of the Sexual Medicine Society of North America, the International Society for Study of Women's Sexual Health, and the Society for the Scientific Study of Sex. He was appointed to the Sexual Function Advisory Council of the American Urological Association, the Standards Committee of the International Society for Sex Medicine, and both the American Psychiatric DSM-5 and DSM-5-TR task forces. For his work, Dr. Perelman has received numerous awards. In 2015, the Society of Family Psychology of the American Psychological Association presented him with their award for excellence in teaching. The American Association of Sex Educators, Counselors, and Therapists honored him with their 2012 award for Professional Standard of Excellence and their 2019 award for Integrative Sex Therapy. In 2022, the Sexual Medicine Society of North America presented him with their Lifetime Achievement Award. He co-edited Management of Sexual Dysfunction in Men and Women, an Integrated Approach, which was published in 2016. From 2012 to 2017, Dr. Perelman served as the editor-in-chief of Springer's Current Sexual Health Reports. He serves on several publications' boards of directors and as a consulting editor or reviewer. He has published over 70 peer-reviewed articles, countless abstracts, posters, and over 25 chapters in sexual medicine textbooks, along with delivering over 300 invited presentations. He writes an invited blog for Psychology Today called The Sexual Tipping Point. Dr. Perelman maintains an independent sex and couples therapy practice in Greenwich, Connecticut, and Manhattan. He works in sex therapy and marital therapy. His work in sex therapy and marital therapy is often featured in the media. Please join me in welcoming Dr. Perelman.
Joe, thank you so much for that kind introduction. I really appreciate it. And thank you to the Faculty Council for inviting me to speak here today. I've had a chance to lecture all over the world, and quite frankly, nothing has been as meaningful to me as this invitation. I really feel quite humbled as well as honored. So thank you. For those of you who find any of this particularly interesting, you don't need to take any extensive notes, as I'm going to put all the slides from this deck on our foundation's website, so they'll be available for free download. And the QR code for that website is up above, and it will also be shown at the end of the talk. Here are my disclosures. And in terms of agenda, there's three topics we're going to discuss. Number one is Dr. Kaplan's work and some of the participants in our human sexuality program. Two, the evolution of the sexual tipping point model. Three, how to take a sex status And then last, I do hope to encourage at least a few of you to consider a subspecialty in sexual medicine. It's really a terrific opportunity. On the left, you'll see a 1971 letter from a former Cornell professor, distinguished Dr. Cliff Sager, answering Helen Kaplan's request that he speak at a symposium she organized through our Department of Psychiatry here at Cornell, which was the first sex therapy symposium that became the Human Sexuality Program. And on the right, you'll see the schedule that I found a copy of events for that program. And among others, most of them are deceased, unfortunately, was the late John O'Connor, who ran the program at Columbia later. Our own Herb Fensterheim, who was a distinguished professor here for many, many years. Irving Bieber, and the Zussmans. The Zussmans were a couple who had recently trained, one of the first with Masters and Johnson, and he was a gynecologist, she was a sex educator, and they also spoke here. Now, Helen's book, The New Sex Therapy, adapted and modified Masters and Johnson's 2-week residential treatment program into an outpatient treatment approach. Importantly, her book became the standard text for most students and medical institutions, having an impact on sexual problems and how they were treated around the world. I met Helen in 1974. I was introduced through a Columbia professor. We both had our degrees from Columbia. She was obviously before me. So I entered her office with a CV and abstract in hand, hoping to get her help with my dissertation. And immediately she quips, I'm wearing my only suit. She's in blue jeans, which at the time was very unusual for a professor at Cornell. And she says to me, with a wall full of diplomas behind me, Michael, I don't need to get dressed up for a meeting. And I sort of got some idea of like what I was in for then. So glancing at my abstract and my CV, she orders, I want you to show up at the Payne Whitney Clinic next week. You'll do your research under my supervision, but I'm very busy and you'll need to get a second reader. And fortunately, Ray Rosen, who helped develop the IEF for Pfizer when they launched Viagra, was available to help me. He was at Rutgers at the time. The program's group was eclectic in the very beginning. Among others, besides myself, it included Avoda Offit, who's now deceased, but she launched the program, the Human Sexuality Program, at Lenox Hill Hospital, Harris Peck at Einstein, Wardell Pomeroy from the Kinsey Institute, and Raul Schiavi, again deceased and missed, but he did launch the program at Mount Sinai Hospital, and he became, following Helen's passing, the editor of the Journal of Sex and Marital Therapy, as well as just a very distinguished gentleman. Based on, by the 1990s, well, let me go back a little bit. At first, we met weekly, watching Kaplan behind a one-way mirror. And at the time, she had me like doing the audio so the people in the room could be able to hear. So I had to get there a half hour early for this. Obviously, whatever young PhD aspires to have as his responsibilities. But by the 80s, on Thursday morning, in advance of our seminar, Helen and a patient would enter a repurposed frozen meat locker on the 3rd floor basement of the old Payne Whitney building. Now, why go into the basement and hang out in a meat locker? It was the only place in this entire institution silent enough to be able to handle the 1-inch videotape, the primitive videotaping that was available to us at the time. But the videotaping really significantly improved the discussions we had in this seminar because the pause, rewind, replay features allowed us to stop, start, kind of like the treatment for premature ejaculation, if you will, and focus in on details and be able to then discuss the session's material from a number of different perspectives. And that was really like amazing because you saw Helen would almost conduct that like a symphony where she's, let's hear from the behaviorist, let's hear from the analyst. And we had all these different perspectives on what were the critical variables in the therapy that was taking place. And yet a lot of it was just her own genius in terms of being able to intuit what needed to be done. By the 70s and the 80s were actually a golden age for sex therapy. Kaplan launched the Journal of Sex and Marital Therapy. Dr. Barbuto told me he just actually was one of the attendees at a workshop we held here at Cornell. It was the first sex therapy workshop that was open to other institutions as well as our own faculty. It was sold out. It was a terrific meeting. But for me, I had published an early article with Helen in 1979, and it actually really benefited my career. Helen would recommend me to go out and do speaking engagements for the invites that she declined. And as she had just married Charles Lazarus, a billionaire from Toys R Us, she really didn't need speaking fees. But for me, this was like a tremendous opportunity. And by the time I was 40, I probably had given a number of them. Speaking of 40, the psychoanalysts in the audience will be amused to view my mother and Helen at my 40th birthday party, arguing about who was better claim for any career success I might have had at that point. Fortunately, the counseling skills taught to me here at Cornell allowed me to help bring them back to a happy place where both felt appreciated for their guidance and support. In the early 1990s, both Helen and myself actually recognized urology's ascendancy in male sexuality. Helen wrote a very good book with Gorm Wagner, a physiologist initially out of Denmark, on how to integrate penile injections, which were new and novel and the better than sliced bread new thing for obtaining and maintaining an erection that the urologists were promoting. But earlier, I had actually volunteered to the urology department to teach their residents in their ED clinic. So I would do rounds with them, do some workshops, talk to some of the faculty. But I also got a chance to observe surgeries. And this was very important because it gave me a much better understanding of male erectile function and male physiology, anatomy, et cetera. So I joined the AUA, the American Urological Association, and I joined its impotence society. So you can see a picture of all the boys on the left there, like, I'm in some corner. But that opportunity actually led Contemporary Urology to track me down and ask me to write a column for them. And I decided to focus it on a concept that was different than Helen's analytic view, dynamic view of sex therapy, and I called it cognitive behavioral sex therapy. And that was the first article that I published for Sex Therapy Today, that column, which was distributed to urologists all over the United States. So a couple people got to know who I was. And that column actually caught Pfizer's attention, and I was asked to be on a panel that launched Viagra at the AUA in May 1998. Now, the urologists got 10 minutes each to speak. There were 4 of us. They gave me 2 minutes to talk about the psychological balance to the medical equation. From the back of the room, the chairman of Montefiore's Department of Urology yells out, "Hey, Michael, sex therapists are going to go the way of the dinosaurs." And, everybody laughs hysterically. I'm, trying to mutter through my talk. So I knew I had my work cut out for me. So I took, Viagra's launch was really a watershed moment. It's really incredible. It crystallized urologists' hegemony over mental health as a go-to profession in the eyes of both the public and medical centers and community physicians. And many urologists, for better or for worse, seem to delight in seeing psychiatry and psychology so unceremoniously dethroned. But I took a page from Helen's playbook, and I kept my seat at the table by publishing over 36 articles over the next 20 years on integrating sex counseling with judicious use of sexual pharmaceuticals. So navigating the limitations and potential pitfalls of working with pharma, I also learned the importance of exposing myself to alternative disciplines viewpoints. This is very important. We'd go around the room, and obviously the marketing people were tape recording everything we were saying to be able to use for their ads. But what we got an opportunity to hear was how each of us approached treating a sexual disorder. So the urologist would speak, the endocrinologist would speak, I might say something. Other people in the room, usually it was a little dominated by urologists at that point in time, so there was a lot of biomedical focus. But that also gave me an opportunity to bring a mental health perspective to the table. But that altered my view from advocating for combination therapies. I thought, well, you know, like, we'll do this, you'll do that, we should do it together, to really think about it more in terms of integration, and later advocating and writing about a transdisciplinary perspective, which is really similar to how many cancer institutes operate today, where there's a true integration of a multidisciplinary group of people, where essentially, like these meetings, you know, I could have given the cardiologist slides. He could have given my talk, because they tended to use all the same people, and there were all these different companies racing to come out with new sexual medicine drugs. So there was a lot of work available at that point of time, both assisting them, but really getting to know each other and getting to know each other's work. Now, no doubt, had Helen Kaplan remained alive past 1995, she would have found great opportunity with the Viagra launch. I mean, she was so well positioned for that with the writing she had done, the world presence that she had at that time. But Cornell's human sexuality program did continue after Helen's death in 1995. My musically gifted colleague, Dr. Richard Kogan, sitting right there, and I co-directed for almost 30 years now. And since COVID, we meet by Zoom bi-monthly, and it's a format that is continued through this day. And by the way, I certainly invite any of you to reach out to us to be able to come as a guest. We would love to have you, and if you want to get more involved, we can talk about that as well. But that is the longest running, continuing sexual medicine seminar in the world. I mean, we've been doing this now for 50 years. It's really kind of incredible how fast the time goes by, but also, you know, the legacy that that establishes for this department. So the new millennium, however, brought a real critical change. So it's, you know, the year 2000. And importantly, new female experts joined the men center stage. So you see that picture I showed before where I'm with a bunch of guys. And then the next two pictures show how the Society for Impotence becomes the North American Society for Sexual Medicine, and the International Society for the Study of Impotence becomes the International Society for Sexual Medicine. And women become a huge part of the picture, and the advances that take place in female sexual health are extraordinary. So if you notice, you know, with the arrows, we've got urologist John Mulhall, a Cornell person who's also at Memorial now, runs their program, and our own Sharon Parrish, who's both a professor of medicine and psychiatry here at Cornell. ISHWISH, the International Society for the Study of Women's Sexual Health, emerged from a Boston pharma-sponsored meeting. So we had a couple meetings in Cape Cod that were sponsored by the government, talking about how science could begin to look more at female sexuality and not just male sexuality. Then Pfizer sponsored a meeting in Boston, and out of that meeting grew the International Society for Women's Sexual Health. Besides myself, Cornell Dr. Chris Creatura, a gynecologist who's in our program, and Sharon Parrish are ISHWISH fellows, and they've made great contributions. ISHWISH was multidisciplinary from the start, different than the other organizations, and it benefited from gynecologists, primary care physicians, a variety of mental health clinicians, nurses, endocrinologists, and urologists. Reams of sex research emerged from female-led labs on all aspects of female sexual anatomy, sexual response, and sexual disorders over the last 20 years. One advancement really deserves mention, which is the clitoral complex. How many of you knew, raise your hand if you didn't know, I'm curious, that the entire clitoral body, the clitoral complex, contains as much size and blood as a male erection? Well, we do have a few very knowledgeable people in the room, so thank you. But it really wasn't until after 2000 that that came out. So I just read a book by Rachel Gross, a New York Times writer, who has a very enlightened, albeit at times heavy-handed, feminist discussion of female anatomical discoveries, because that's really taken off in the last 10 years. You know, at Hopkins, they had done nerve-sparing surgery for prostatectomy many, many years ago. And the physician who did that, the surgeon who did that, would spend hours with cadavers trying to dissect the nerves and understand what nerves were connected with having an erection, so that when he did the prostatectomies, he could spare those nerves and hopefully not have the same degree of then impotence and urinary problems that plagued men who had had prostatectomies. But nobody had done the same thing for women in terms of hysterectomy and, you know, various surgeries that take place for rectoceles, et cetera. So that actually is being done now, and that's really a huge improvement and enlightened. There we go. Helen studied art in Paris before she immigrated to the United States. And one particular sketch that she did for her last book really had a profound influence on me. That 1995 sketch foreshadowed both psychiatrist John Bancroft and my own work on dual control models, which have essentially become the sort of standard for understanding what goes on in sexual response and sexual disorders. I focus primarily on the clinical applications and implications of a variable dual control model, which I called the sexual tipping point. It did receive some notice, and after filling out many forms, the STP was finally granted a trademark by the US Patent Office in 2007. So I was like, you know, really happy about that. But what also helped was NIH sponsored a summer institute for urology fellows who were both getting PhDs as well as they're having MDs in the research that they were doing. But some of it was so esoteric, they wanted somebody to speak to them about how they could communicate to the larger public their scientific discoveries. So these things that were fairly obscure could be found to have the importance and meaning necessary. So that was a big opportunity for me to go there and talk about that with them. But some of you are going to be amused to know that the patent office makes the DMV, you know, look easy. Their lawyers inform me, you can't patent an idea, Michael, but only an object. So one of them suggested, you can throw out hats or T-shirts emblazoned with the STP logo at your lectures. And, you know, somehow I didn't think that was appropriate for a Cornell professor. Instead, I did place an order for inexpensive mechanical pencils that were emblazoned with, you know, ask me about the sexual tipping point, because that allowed me to get the registration. Once you have a registration, then you can go ahead, and now our foundation owns the rights to all sexual tipping point materials, whether analog or digital, for any use in clinical use, education, or research in the United States. Can't get an international patent from the US Patent Office, but you can have some influence here. So I used to give these out periodically at lectures, because the other thing they told me is you have to distribute your product nationally if you want to maintain your registration, because every 5 or 10 years you have to renew it. So I started out with 300, and I only have a couple left, but I did bring one for Dr. Barbuto for today. What really enhanced the model's acceptance, however, came unexpectedly. I was trying to explain to a multidisciplinary group, one of these ad boards, that Behringer was running, a neurobiology ad board, for flibanserin, the treatment that was designed for women's sexual desire problems. Jim Faust, the famous rat researcher, thought this was hysterical, and he films me. But he also included an illustration of the model in his highly cited article, Pathways of Desire, that was published in the Journal of Sexual Medicine. And that really put the sexual tipping point model on the map, so to speak, for people who are in my particular subspecialty. BI had also hired a media company to produce images for them, and Shaw Science licensed the model for their animated film that they were going to use in commercials and marketing practices that explained desire. So I started a foundation then and donated the rights to it so that money could go to encourage young sex researchers. And that's how I was planning on sourcing these awards that we ended up giving out. But after spending about $500 million, BI left the sex and the movie business, the sex med business, selling fulvancerin to Sprout Pharma in 2011, after fulvancerin was rejected by the FDA again in 2010. FSD drugs continue to be debated by stakeholders who desire them versus those concerned with medicalization and pharmaceuticalization of female sexuality. Despite that, Sprout eventually received FDA approval for Addyi in 2015. But I kept the foundation as a legacy project for myself, raising money through friends. And since its inception, I'm actually very proud of this. We've given away 23 Sexual Tipping Point Award certificates and $1,000 prizes. The foundation's website and social media now has over 500,000 views. The foundation publication and presentations have been downloaded in more than 135 countries, providing global access to help patients. Obviously, I've been in private practice for almost 50 years, and I don't get to see that many people at all. But the idea that you can have influence by using technology actually appealed to me. Next, I want to discuss the sexual tipping point model itself and how it helps optimize the treatment of sexual dysfunction in terms of taking a history. I know it's complicated, but keep in mind the red colors are always excitement, the blue is inhibition, and it refers to a list of relevant mental and physical factors, one on each side, where each may be inhibited or excited, and only key factors are listed because there's probably a million factors, many of which haven't even been discovered yet. So the mental factors listed are thoughts, emotions, relationships, culture, sexual script, the phenomenological experience the person has in receiving touch as opposed to the actual physical touch, and things that are unknown. Science is constantly progressing. We're getting more and more information about how all this works. And I wanted a model that would be both simple, like, hey, it's hot or not, and yet had the complexity to be able to incorporate new discoveries for decades to come. The physical factors are anatomical, drug and alcohol effects, endocrine, genetic and epigenetic, neurological, stimulation or actual touch, the physical touch, the friction, again, the unknowns, and previous medical or surgical treatment. Same thing on the mental side. I was tracking whether or not they'd been in some kind of therapy or not, whether or not that helped or it didn't help, because that's going to be a factor as well, obviously. And in this particular cartoon, I use sliders to demonstrate variability, but dimmer switches are also used, and they're essentially equivalent. So I know this sounds complicated, and I'm going to try and make it a little bit more simple so it's easier to understand. The STP is an easy way to depict both the mental and physical elements of sexual function and dysfunction that facilitate an integrated treatment approach. Now, why? Because sexual response is an endpoint representing the sum of every thought, behavior, emotion, culture, not just biology. Now, of course, this mind-body concept is older than Descartes, not just George Engel and his psychosocial model, biopsychosocial model. Now, the sexual tipping point is a threshold at which an individual experiences a sexual response at a given moment in time. So that's going to change. Well, if you think about yourself, you'll have sexual thoughts during the day, but there's all kinds of other stuff going on. So your genetics haven't changed, your biology hasn't changed, but how you're feeling is going to be shifting throughout the day, of course. So this is a model that can tell you, like, at a moment, what's going on and what's determining that. So the STP balance beam can illustrate all the intra and intra-individual variability characteristics. Now, these intra-individual variability is critical. You're on the subway, you're holding on to the pole, it's rocking back and forth, you close your eyes and you're remembering a pleasant sexual experience from the night before and your partner's touch. And you kind of have a little smile on your face. And then all of a sudden, some creepy guy comes and presses against you and touches your hand. The exact same physical stimulation in this new context evokes completely different response, yet you're anatomically haven't changed, your genetics haven't changed, nothing physical has changed. That's all in your mind. So there's always this integration going on that we have to be aware of. So there's differences between people, but there's differences between any given individual at any given moment in time. The balance beam can illustrate that. And in this cartoon, the biological or physical elements, with these like overweight guys at the counter, are obvious. But as is the health David would need for optimal functioning on the other side of the equation. So it's going to kind of go back and forth, and you're dialing this up or down depending on who it is you're speaking with. The multitude of factors that determine sexual responses are depicted as variable dimmer switches, as they're not binary on and off switches, but continuous, reflecting their endless variability. Each dimmer is like a microvariable switch that symbolizes a factor's varying polarity. Some are positive, some are negative, some are sort of neutral, and some are still unknown, and yet they have to be part of the picture. Magnitude is shown by the size of the dimmer, if you will, of the slider. The color shows the polarity. The net sum of all these factors determine the STP, and it's shown on the sexual balance beam, again, at any moment in time. It also illustrates with color changes a normal distribution curve. So if you look at the backboard of that balance beam, you see I've put on it a normal distribution curve. So, 2 standard deviations away, it's like red, they're excited, they're turned on. You can go 3, they're really turned on. But the opposite can also be true. And every one of those factors would begin to move that in one direction or another at a given moment. And again, the sliders and dimmers are interchangeable. It's just, Helen was an artist, but I'm pretty good at PowerPoint. So I made all these things using PowerPoint, and quite frankly, it takes a lot of time. Many of these factors are bidirectional. Excitatory and inhibitory processes can occur simultaneously, in fact. You can have both going on at the same time, and their balance determines the overall sexual response. So changes in polarity and magnitude can be bidirectional. For instance, mentally, a once desired touch, like we were just talking about on the subway, can become traumatizing after rape. Feeling great helps, illness inhibits. Despite that person having the exact same genetics they were born with. One day you're feeling great and you're having a sexual experience. Another day you just came down with COVID, you're feeling like you want to die. You're not going to be very interested in sex. But your physiology, in terms of your genetic predisposition, nothing has changed. So you need to be able to account for both. Drug effects, which many of you are obviously familiar with, can be bidirectional. Viagra can help excite. High blood pressure medications can inhibit. Obviously, many of you have experiences with antidepressants and their impact on orgasm, which tends to even be more profound for women than it is for men. And common objects can become fetishes, sort of like Mrs. Robinson's stockings in The Graduate. Now, that's a movie reference that dates me a little bit, but I'm sure you get the idea. So this cartoon is now depicting because I wanted to try and just break it down. How might this apply to a real patient? To a man that was referred to me for ED treatment, secondary to his ex-wife humiliating him. She, in open court, she calls out, "You were the worst lover I've ever had." The judge tells her to be quiet, but this guy is like, he can't believe what he just heard. So he comes to see me 2 years after the incident, and the cartoon shows the breakdown of various potential factors relating to his chief complaint. So these are the things I was thinking about. The M's mean mental. I think that's a little hard to see, so I'll just describe it. The M's are mental factors, the P's are physical factors, and then they're numbered to correspond to which one of those factors that we're referencing. So I want to take a pause for a moment so we can read the list. I think that's visible, yeah. But we're talking about, mentally the thoughts, how they can inhibit erection, upsetting feelings, humiliation, confusion regarding interpersonal relations. He once tried to engage with another woman, and there was sufficient friction, but that friction wasn't sufficient to override the psychosocial factors. So he wasn't able to get an erection, and he felt humiliated again, and then avoided dating for a long time. So he goes for psychotherapy, a supportive psychotherapy, and unfortunately that, not really surprisingly, did very little for his erectile problems and his avoidance of dating and women. What about physical? I would say he may have been anatomically predisposed. Why? Lots of people have negative experiences, people say mean things, and you don't necessarily, fold all your cards just because of that. Some people get headaches, some people get stomach aches, some people get sexual problems. He was probably predisposed a little bit. Doesn't really matter for the treatment, but just for your own understanding. So maybe it was pervascularization. But he was also drinking too much to help cope with his bad feelings. He also had a low testosterone level. We had that examined. Now, I do think he was genetically probably predisposed to have erectile dysfunction, but we don't have no way of testing that at this point in time. And part of that predisposition is probably less neurosensitivity. When he's touched, he may not feel exactly the same degree of exciting sensation that somebody else might. And then there's things that are unknown again, and those are going to weigh in, even if we don't know how to describe them. And then importantly, he went to see his urologist soon after this happened, after he first tried to have sex again and failed. And the urologist did prescribe a PDE5, whether it was Viagra, Levitra, I don't remember. But he gave him insufficient dosing instructions, and it didn't work at all. And he was even more devastated. And it was actually soon after that he went for the supportive therapy that also helped him feel a little bit better about himself and not feel so bad about what she said, but meanwhile he still wasn't able to function. Now, I really don't expect anybody else to diagram all this like some 5th grade English homework assignment. I get that. But it highlights the way granular, multiple, discordant factors interact, yet in the end produce a simple result. The person is functioning or they're not functioning. And it really highlights all the different etiological factors that need to be considered. The sexual tipping point reminds us to consider all relevant factors, not just the ones that are easy to observe and recognize because they're comfortable for us based on our own training. Too many of us are siloed with limitations that our own profession of origin have influenced. Too often specialists engage in myopic patient treatment because of that. And that's really where I come around to this notion of continuing education for all of us and integrating more knowledge from other professions. So far the takeaway is SD is always determined by biomedical, psychosocial, and cultural factors. An individual's sexual tipping point at any given moment is determined by the net sum of those factors. Identifying the factors allows you to plan your initial interventions. And finally, if you summarize your understanding to the patient, you can inspire patient cooperation and hope. So how do you identify these factors? The answer is a sex status. So you're like a sex detective when you're doing this kind of work. A good sexual status gives you like a videotape, a video picture in your mind about the friction, frequency, fantasy, and feelings the patient is experiencing. It'll allow you to identify the factors that are currently maintaining the distressing sexual disorder. This is critical. We're looking at the here and now, what's currently interfering with that person's ability to function. There may have been all kinds of psychosocial, historical issues that would be of very interest dynamically to a dynamically oriented therapist to try and uncover and help the patient understand. But that's not what we're doing. This is sort of top-down rather than bottom-up. Depending on the patient's responses and comfort level, as well as your own, because some people find it difficult to speak explicitly about sex, probe for the needed details and sexual experiences that illuminate the key factors. These details do raise the question of how interactive do you want to be? Who do you wish to be as a therapist? Can one work dynamically this way? Helen did, and she was a psychoanalyst, but then again, she became more directive as time went on. So it's your choice, but if you're knowledgeable about how to do this, you'll have the capacity to treat yourself, and you still have the option, if you prefer to maintain a particular frame, of referring out for adjunctive sex therapy. So I always ask this one question. I ask about their last sexual experience. And one young Orthodox Jewish couple took real exception to this. He had never ejaculated. He was referred to me by his urologist because they were planning to electro-ejaculate him so they'd be able to do artificial insemination. And this very young couple, 19 and 20, would be able to have their first child. So they come in to see me, I ask them this question, and they start talking Yiddish to each other and giving me dirty looks. And then, the guy says, just because we're Jewish doesn't mean we're not normal and that we don't do it in the normal way. And I say, I'm Jewish also. And they go, yeah, but we're Jewish, he says to me. But I ask him anyway, I said, this is really the only way I can help you is if you can tell me a little bit more about it. He goes, well, like I said, we do it in the normal way. I go inside her and I wait. I go, okay, and then what happens? He goes, I wait some more. I say, and then? He says, well, I wait some more, and then it gets soft, it falls out, and we try again the next day. So I say to him, do you ever move? I use my fingers a lot, when I'm talking sometimes. And you see the light bulb go off on these young people's faces. We schedule a follow-up appointment. I had told them that you might want to try this, certainly before you do the electroejaculation. They come back in to see me. They tried it a couple times, didn't work at first, but by the third time, they were able to have successful sex, and they were very, very happy. We schedule a follow-up appointment, and not surprising to any of you who've worked with couples from this particular population, they canceled the appointment and, never heard from them again, despite attempting to reach out to them. So I hear from the urologist who made the referral that she's pregnant, it's a couple months later. Turns out she ended up having 8 kids. Now, how do I know about this? Because every year at this time, a box would be delivered, a box of matzah from Brooklyn with a note that said, Dear Dr. Perelman, you and your family should have a very kosher Passover. And thank you. So what are the critical evaluation issues? I'm asking you to get a lot of material. How do you know what's critical or not? First of all, do they have a sexual disorder? What's the diagnosis? Second, what are the underlying biomedical, psychosocial, and cultural factors? Just because you're going to start with what's maintaining doesn't mean you don't want to have some understanding of what else is going on. And importantly, do any of those underlying factors require pre-treatment, or can they be bypassed, modified, or treated concurrently? For instance, severe depression. Some of you are going to be more comfortable treating that than others. Severe marital conflict, drug or alcohol abuse. Usually these things require some pre-treatment before you can go and focus on the sex. So people who we've trained are able to do both. Other people are more likely to, refer out. for those treatments. Again, you want to identify the factors that are predisposing, precipitating, exacerbating, or maintaining the disorder. And where do you begin? As I said, you begin with the immediate cause that are currently maintaining the problem. Resistance to that, which is inevitable, will occur to behavioral suggestions. It's not like you tell them what to do and they just come back the next week and it's a success. But that's going to illuminate deeper causes, which can be bypassed or, again, explored as needed, and then you return to more of a directive treatment. Years ago, sex education used to be enough. We had a very unsophisticated population as opposed to with, all the stuff on the internet now. There's continuous education about these things, some of it correct, some of it incorrect, of course. But that was all that was needed. So a 50-year-old married man with ED was referred to me by his urologist who had scheduled him for penile prosthesis. So he asked me to see him for psych clearance prior to placing the implant. This guy was a marathon runner, but injury had sidelined him a decade ago. But he still woke up early every morning and he ran 5 miles. He reported previously active sex life until a year ago, which is why he went to see the urologist. And he seemed very content with his marriage. So in session 1, I asked him, after some of these other questions that we were just talking about, I asked him what he thought the impact on his sex life might be if he cut the running back a little bit. He laughed and he said he would give it some thought. So we scheduled a follow-up session a couple weeks later. He canceled that 6 days before and left a message that he cut back on the running, he's getting more sleep, and they had already had sexual intercourse successfully twice, and both of them were thrilled. Fortunately for me, the urologist still refers to me because, of course, he canceled that surgery. A sex status at follow-up will reveal the initial causes of potential treatment failure, whether current or superficial, right? So you keep going back to getting these details. And deeper issues, again, may require intervention. But you just pivot and adjust the timing of your interventions according to the pushback you receive. Now, using this approach, patients can be weaned from medication, or it can be reduced further, improving the risk-reward ratio. So I see these PDE5 drugs, for instance, as something that can help somebody who's got a severe problem, and then you can gradually get them using less of the medication or wean them completely from the medication. Just like if somebody has a headache, they'll take an aspirin. If you don't have a headache, you typically aren't taking Excedrin every day, or you create other problems. So I see these drugs the same way, and especially with young men, because there's so much, again, on the internet with the distribution through these various companies where you can just go online and essentially get a prescription 15 minutes later after a 10-minute screening phone call from a physician. By the way, do you know, this surprised me, maybe you guys would all realize this, but I'm on the advisory board for Roman, for Roe, which is one of these companies that you see advertising. So I asked the fellow that runs it, the CEO, I said, like, by the way, who are these doctors? And, I'd like to take a look at the protocol they're using. I said, these are retired urologists or psychiatrists. Who are these people? He goes, no, actually, they're women who've recently delivered and they're stay-at-home moms, but they can pick up some extra money by handling these phone calls. So clearly these guys are getting the medication prescribed at a fairly low threshold of focus compared to the kind of in-depth stuff that we're talking about here. So with younger men in particular, what I'll say to them is I'm sure new things are going to be discovered that'll help you when you're like my age. But for now, why don't we see if we can get you functioning and then cut back on the medication, have you build your confidence, have you build your understanding of your own sexuality so that you're able to function with less of the medication and then wean yourself from it so that when you're older and maybe you're on more other kinds of medications that interfere, your health isn't as good, you've got something to fall back on. Because if you continue to rely on this now, this quote-unquote crutch, you are going to have a little problem in the future. So this is something I'll discuss very explicitly with the patient. So obviously the frame I'm using is a very open and communicative one. with the patient, which is certainly different than how many people might be doing therapy, and how it's different from how I might do therapy myself when there's a different kind of presenting problem. But the SDP model is applicable to all people. Yet as a cisgender man at the end of my career at 75 years old, I primarily limit my public commentary to issues of concern to men. I do, in my private practice, treat men, women, couples of all different gender identifications and marital and relational status. But I tend not to give lectures about female sexual disorders unless I'm doing it with a colleague at invitation, typically a female colleague, at a meeting like the International Society for Women's Sexual Health, which is where I was at the end of this presentation momentarily. But the most important issue to clarify, for instance, let's just talk about a couple of these male problems, just so you have some tips about how to treat them if they come your way. The most important issue to clarify is whether a man with premature ejaculation can differentiate his premonitory sensations. Those are sensations like, hey, I'm getting pretty close. I feel like if I keep this up, I know I'm going to come. So, increased heart rate, increased respiration, kind of a tightness in your butt, your toes may curl or splay out. From emission is when the fluid is deposited remember I used my fingers, at the base of the penis, and then 2 to 4 seconds later, striated muscle contracts rhythmically and fluid is spurted out. Whereas the guys that try and hold it back will end up with a partially retarded ejaculation where it sort of just dribbles off the top. It's because of these different stages. They need to learn about that. So premature ejaculation patients usually relapse when withdrawn from urological treatment. So there's a lot of drugs that can be used, creams, lotions, potions, that will help delay ejaculation, that will affect the intravaginal ejaculatory latency time, is how it's described in the research. But typically, when they go to see the urologist and they stop using the product that they've been given, and sometimes even with that product, if they have a severe problem, they'll go back to the urologist, cancel the appointment, ask for a referral, and that's where you can come in. Medical approaches, whether they're pills, topical creams, sprays, emphasize symptomatic improvement without considering long-term learning, relationship issues, or the relapse with discontinuation. So they usually relapse when withdrawn from these treatments, and that does generate the referral. Medical approaches, we're not changing the slide here. There we go. So what does he have to do? He needs to recognize a clue before it happens. He often doesn't realize when he says uh-oh, I'm going to come now. He's actually coming. What's happening is he's confusing his emission, which is the first thing he's noticing because of anxiety and a lot of muscle tension, because he knows he's going to come quickly, and he's hoping he won't, but nonetheless he's tense. So what bursts through that tension is actually the emission, the depositing of the fluid. So he feels that and he goes, uh-oh, I'm getting real close. But in reality, it's not, uh-oh, I'm going to come now. It's, I'm in the process of coming now, and 2 to 4 seconds later, fluid's going to come out. And if you try and hold that back, it's just, again, going to dribble off the top, and then you'll lose your erection. So I wrote an article for Psychology Today, why premature ejaculation is a reflex like a sneeze. If you have to sneeze, if you feel that tickle and you blow your nose, it's all fine. But if you wait till you're, and before you hit chew, you try and blow your nose, it feels like you're blowing out your eardrums. This is much the same way. It's a reflex. So men confuse their premonitory sensations and the submission phase. And it's really too late then for him to stop or slow down. So sometimes I'll use a yellow light, green light, yellow light, red light analogy to help them understand. It's not like New York where you had a yellow light, you drive faster so you can get through the intersection. You hit a yellow light, you better stop initially, pause, get the lay of the land, and then start again slowly. And then gradually you can shift into that yellow light you can slow down, you can move in a different way, you can change positions. So it's a gradual approach to teaching him. When it's a really severe case, then I will ask for the person who referred, the physician who referred to me, to prescribe whatever they feel might work best, and we usually discuss it. That would help physiologically slow him down, because these are people who are typically predisposed to this particular problem. And he's got to reset his threshold, reset his ejaculatory tipping point, if you will, so that he has the time where everything's moving a little more slowly, so he can recognize those more subtle sensations in his body and do something about it. Then once he learns to do that, we can start reducing the use of the medication. And once accomplished and differentiation is established, you can take them off the medication and they will not relapse, unlike the urological treatments. So moving along, here's my thoughts on the future of ED treatment, as shown in this cartoon. What it describes is an integrated treatment for ED, secondary to, these are men have a metabolic syndrome. You can see Fat David on the right side, all up in the air. And a PD5 is integrated with sexual counseling and a little luck from the hand of God. You can't just think, oh, this is going to work because you're clever. When I first made this slide, though, interestingly, I presumed the new drug that would get developed would be some kind of a new drug for erectile dysfunction. It turned out what happened before that is we've got Ozempic and people are losing weight. And so they're in better health, at least physically, feeling better about themselves. Whether or not this helps ED or not, we haven't researched that. I have no idea. But there's no question there'll be continuous evolution of these treatments, and yet all of it is going to require the kind of counseling skills that all of you have. But what I do know is that DE, delayed ejaculation, is a disorder that many of you could treat better than most urologists. Why? Delayed ejaculation is a disorder which should capture your interest. I've treated over 500 cases. That at this point is more than practically anybody in the world. And I've written about it extensively. But treating DE is a big opportunity for mental health professionals. Why? There are no FDA-approved drugs, treatments for DE. So these urologists are constantly talking about how difficult it is to treat this problem. And yet, for any of you, you'd find it much easier just based on your training. Despite many reports of experimentation by physicians that seek a pharmaceutical to reduce coital latency time, there is no high-level evidence to support these anecdotal claims at all. It's all just anecdotal, one-off case studies or very small studies. Now, obviously, there's many biological and pharmaceutical potential causes of delayed ejaculation, and many of you will be familiar with them, especially as it relates to antidepressants. But if you take a look at this, you've got a sluggish reflex, so it's biologically predetermined. You've got antidepressant side effects. There's a number of central factors that can make a difference in terms of serotonin levels, et cetera. Oxytocin, dopamine, and pudendal nerve variation for these men. But that's all interesting, but none of that is going to get cured by any medication known to man today in any way that's been demonstrated, evidence-based and clinically. So surprisingly, the AUA Guidelines Committee for Ejaculation Disorders concluded, quote, urologists should consider referring men diagnosed with lifelong or acquired delayed orgasm to a mental health professional with expertise in sexual health. Not a common suggestion from urologists for them to be recommending us. So what's different? Overwhelmingly, these DE cases are situational. They only occur in certain types of stimulation, situations, or partners. The vast majority of sexual disorder patients are complaining about not coming during intercourse. They can orgasm with masturbation. So a recent study I did, actually using some data from Cornell, 90% of the men were able to masturbate successfully, yet they were unable to come with a partner. So Why? Using the ideas I've discussed, you can all treat this. A good sex history will expose the psychosocial and cultural reasons for DE. Most typically, you're going to see insufficient penile or psychological stimulation, high-frequency masturbation and/or idiosyncratic masturbation. Idiosyncratic masturbation, a term I coined, just referenced the type of stimulation that your partner provides that's different than what you provide yourself by using her hand, her mouth, her vagina, or her anus, or any other body part. What you're experiencing, the quality of the friction is different, and that difference isn't sufficient for you to be able to ejaculate, given the conditioning you've caused yourself with masturbation. Some of these men do have a preference for masturbation over partnered sex. Some of them do have psychological conflict regarding ejaculation, whether it's pregnancy concerns or defiling a partner, etc. And these issues obviously overlap. But the most important question to ask is for the person to consider whether or not their masturbation differs from their partner's stimulation style in terms of speed, pressure, etc. And ask him to think about the type of friction experienced during masturbation. What are his thoughts, importantly, during masturbation? Pleasure, what are his fantasies, or what pornography does he use? Has he communicated these preferences to his partner? If so, what was the partner's response? Now, if you or your patient are uncomfortable with this strategy, know that there's accumulating evidence that indicates men suffering from DE masturbate in a manner that's different in the ways that I just described. Understanding how they stimulate themselves, and if it differs from partner, is going to help you be able to assist them. Now, to make this easy for those of you for whom such talk would be difficult, you can provide your patient with an easily understood Psychology Today article I wrote called Why Delayed Ejaculation is More Common Than Folks Realize, where I just break this down very simply. And they'll come back and you can use that article as a way of getting some of these questions asked if you're uncomfortable asking such details yourself. So the solution is to temporarily increase his ejaculatory frequency, decrease his frequency, find ways to increase the quality of friction and erotic thought. Typically, he has to suspend masturbation activity and limit release to whatever his desired activity is. So typically, they're looking to be able to come during intercourse. But if they want to come with oral sex, they want to come with anal sex, they want to come with manual stimulation, whatever it is they want, he has to commit to not masturbate. Now, typically, what this does is obviously lower the threshold for ejaculation. If he's used to a daily release and he doesn't masturbate for 2 weeks, believe me, it's going to be easier for him to come in response to partner stimulation. One thing I did want to say about this was if they don't believe you, here's a simple thing. Ask him to switch hands. So if he's normally stimulating himself with his left hand, ask him what happens when he uses his right hand. And I guarantee you it's going to take longer. He still may be able to come with masturbation, looking at porn, but if he's using his right hand, he's going to get a different experience than his left hand. But it's the same brain. So I will say to him, your brain has perfect communication. So this notion that like it's a communication problem, you haven't communicated with your partner, or your partner doesn't understand you, or is unwilling, or whatever. The fact of the matter is, if you can't do this yourself, how do we expect her or him to be able to do this for you? So whatever it is you're doing, we need to start changing that up. So for men who just say, look, I can't go 2 weeks without having an orgasm, it's just not how I'm built. I'll renegotiate that to change the technique they're using so that you begin to take that porthole and turn it into a picture window in terms of what they're able to respond to. By the way, these most read notifications are less a sign of my writing abilities and brilliance and much more an indication that sex sells. Writing about it for 50 years gives a lot of time for folks to read your articles. But developing this subspecialty is really an opportunity to impact a lot of lives positively. People really care about your helping them get back to sexual intimacy. Being able to prescribe, I think psychiatrists are primed to be the link between the various disciplines that claim sexuality expertise. I mean, I've got to get somebody else to prescribe for me if I think they need medication to adjunctive or supplement some of the counseling I'm doing. But any of you with the ability to prescribe and your training in psychosocial and cultural issues would be able to do this yourself. And that was really Helen's advantage over many of us. And for you non-physicians here today, there's also a very real opportunity as sexual medicine is an ever-expanding field. You know, again, sex sells, it's something that's been of concern since pre-biblical times. But last and not least, I see Dr. Lee here in the audience. I really want to thank Psychiatry's, Cornell Psychiatry Department for the opportunity to have represented us in writing and presentations around the world. I really appreciate having been here for the last 50 years. So thank you all for listening. Hi. Great.
So thank you so much, Dr. Perelman, for a fantastic, very interesting talk. So I'm Riley Slattery, and I have my co-chief, Tegan Donnelly, on Zoom. We're going to start alternating to get your questions answered. Just a reminder for the in-person audience, please introduce yourself so that the Zoom audience can know who you are. And I think we're actually going to start with a question on Zoom. So go ahead, Tegan.
Okay, thank you. This is a question from Albert Ortega. The models used to understand and treat sexual dysfunction are based on heterosexual relationships. Are those models helpful in addressing sexual dysfunction in same-gender relationships?
I think that's a great question. If everybody didn't hear it, essentially we're talking about, does this model apply to anyone besides those who are heterosexual? And while the majority of my experience, I would say in the first 20 years, was disproportionately heterosexual folks, over the last 50 years, I've certainly treated a number of people from a variety of sexual orientations as well as gender identification. And the model fits because you're really talking about what tips the balance for that particular individual. And this is also where the cultural awareness comes in, because I think all of us need to be more culturally aware, given how flat the world has become. And with the internet and the ability with Zoom, like we're doing here today in this hybrid grand rounds, you are able to reach people all over the world. And many of those people, especially those doing research to be able to identify you, to talk about a sexual issue with you, are going to be from a diversity of backgrounds and orientations. So thank you for the question.
Okay, we have another question from the Zoom audience. This is from Jim Neininger. What is the current role, acceptance, and indications for the use of sexual surrogates in treatment for certain sexual dysfunctions?
That's actually an excellent question as well. At Cornell, I can assure Dr. Lee and the rest of the administration that we've never used a surrogate, but we had the clinic. The clinic hasn't been in operation now for 20 years. It actually had stopped, and we were just doing the seminar at this point. But even in our private practice, most of us don't use a surrogate. I've never used a surrogate. Then again, Dr. Barbuto had asked me about this, and Dr. Kaplan actually did have a patient many, many years ago where it was actually a faculty member's son who had been burnt in a serious accident, who was afraid of being intimate and avoided any social contact because of it, where she decided to use a surrogate, which was extremely effective. The woman was a nurse and able to encourage this young man to recognize his other benefits and talents. That said, Helen was very skilled. The surrogate was extremely skilled. It's a nice story. It worked out well. It's a beautiful tale. I've actually debated surrogates on national television about the appropriateness of that as a choice. Number one, for years, and I don't even know the legality of it at this point in time. I believe it's still legal. That was problematic. especially those of us that are licensed, doing something that was against the law would not have been a smart move. But that aside, because I do have colleagues who have used surrogates, and many of them have had good experiences with them because they've been in communication with the surrogates have been ethical. But again, with the rise of the internet, let alone what used to be in the back of New York Magazine as advertisements, this was a very sort of dicey situation. Now, that said, there is a surrogates association where these people have pulled together and have tried to establish some type of certification program. There's male surrogates that disproportionately work with homosexual men, but also work with some women, especially older widowed women who are interested in re-entering the dating situation. But I personally don't do that, and I'm not comfortable doing that, and haven't found it necessary to be able to help people. I know others have. I hope that answers the question.
Hi, my name is Nathan. I'm a psychiatry PGY1 here in the audience, right here. You'd mentioned, working with urologists or psychiatrists or other mental health practitioners. I'm wondering if you work with other kind of allied healthcare professionals in your practice, and if so, what that looks like.
I do, and I would tell you that a real movement in the the North American Sexual Medicine Society is to use quote unquote physician extenders. So the urologists actually have some really, really well-trained physician associates and specialized nurses who work with their patients, providing the kind of connection, education, follow-up, availability for a quick phone call that many of the surgeons just don't have the time to do, even if they had the inclination. So it's both economically beneficial to the surgeons, but it's also highly beneficial to the patients to have somebody who's knowledgeable beyond that particular professional they went to see in the first place. And those people are proud to be allied professionals, and the society is actually now beginning to certify them as having sexual medicine expertise. Any other questions?
I have a question.
Yes.
So hi, Dr. Perelman, I'm Riley. I'm wondering if you have any books that you recommend, either for couples work or family work, or obviously for sex problems in marital relationships.
I think that's a good question, but if you think about, there's so much out there that I wouldn't even want to give a list, but I can tell you what I do. What I'll do is something catches my attention, I'll read that article, I'll read that book, and then I'll take a look at the bibliography and I'll start examining it. It used to be, I'd have to trek over to the library here, they'd have to order it from some other medical school, you'd have to wait 2 weeks for it to show up. Now I'm sitting at my home, I just pull it up on the internet, draw it down, read it. I think this kind of cross referencing that is available to you today so easily using the internet provides tremendous opportunity. So what's interesting to me is I've actually, in part in preparing for this lecture, went back and looked at a couple of Masters and Johnson's early books, a couple of Helen Kaplan's early books, some of my own writing, and some of my colleagues' writings, and been impressed to see the threads that retrospectively you can see coming together. But I know you would ask me a question about another case, and you can just Google, treatment of, and you'll see a number of articles as opposed to some of the, the stuff on Instagram, and you can pretty much tell because some of them are rated now by these various services, and you can just see which are the most cited, and have a better idea of how to identify something that's going to help you with that particular problem. And then if you take a step back and try and get more of a global appreciation of the theory that they're coming from and see who their influencers are, it'll just depend on how much time you have to read. But thank you.
I guess I'm also wondering about resources for patients. Are there any kind of favorite books about couples and
I'm
marital
such an old
relations
guy,
that you
I
would
still
recommend
use
patients?
like some things that are, for male sexuality, Bernie Zerbergeld, who's again deceased, wrote a great book called The New Male Sexuality. It really sort of integrated these things. He suffered from diabetes himself, so as a psychologist, while he was oriented toward psychosocial issues, he really had an appreciation of medical issues because it impacted his own life. Lonnie Barbeck, out in California, who wrote For Yourself, was really the first book that, in fact, she and I got our PhDs like the same year in 1976, and she wrote a book called For Yourself, and that was the first book talking about teaching women to use vibrators to give themselves their first orgasm. And it's such a classic, it's worth looking at. Now, that said, you can Google, like, how do you have your first orgasm? And it'll give you all kinds of stuff. And once in a while, there'll be some professional references attached to that, and you can take a look at those. I hope that helps.
Perfect. Yeah, thank you. We have a question on Zoom.
Okay, this is a question from Martin Cohen. How are men who have retarded ejaculation treated where there is an issue with masturbation itself as well as partner activity?
I think that's actually a very interesting question. I appreciate that coming from Marty. I know he has a lot of experience himself. You're talking about a primary ejaculatory disorder, meaning regardless of the type of stimulation, this person presumably has had no ejaculation. So the first thing to do is to take that good sex status that we were talking about. But then you're also in a situation like that going to want to make sure that there aren't any anatomical problems, hormonal problems, which will require referral to a trusted colleague that you're going to be able to discuss these things with. So whether or not that's going to require some surgical repair to an ejaculatory duct, hormonal supplementation because they're free testosterone level. Actually, that's something that's important. Most of you will know to take a testosterone level when there's low desire or erection problem, a problem with arousal for women. Women obviously need testosterone as well as estrogen, just like men have estrogen as well as testosterone. But serum testosterone is the testosterone in your blood levels, whereas free testosterone is what is accessible to both your brain and the receptor sites in your genitals to be able to activate the response in a way that one would expect. So you want to get free testosterone levels as well as serum testosterone levels. So for somebody with retarded ejaculation that's primary or delayed ejaculation, and by the way, these are mutually exchangeable words amongst professionals, but patients have objected for obvious reasons to being labeled as, retarded ejaculation because of the worse use of the word retarded, but that is what it used to be called. I hope that helps, Marty. If you want to follow up and send me an email about it, I'm happy to discuss it with you offline in greater detail. Anything else before we stop?
We have one more Zoom question.
Sure.
This is from Albert Ortega again. In the early 80s, some in the field of sexual therapy work focused on conversion therapy. A mentor, David Barlow from BU, has since apologized and communicated sincere regret about his research. What was the thinking at Cornell in the early 80s regarding conversion therapy, and what can we learn from that period?
I think that's also an excellent question. That was taking place at a time where in DSM-3 and DSM-4 we're shifting the view of homosexuality. I almost lost my job at the Institute for Behavior Therapy because at the time in the 70s, they were using electric shock to try and quote unquote convert people from one orientation to another, from homosexuality to heterosexuality, and it was something I refused to do. They were unhappy to me because I was so junior, so to have the chutzpah to tell a supervisor that that's not how I'm going to handle this was problematic. But certainly people were writing in great detail about what some of the, in the 70s in particular, about the underlying issues that may be causing from a psychosocial perspective. And by the way, there are underlying issues from a psychosocial perspective that can alter and influence both gender and orientation. But disproportionately, most of, and certainly amongst, you'll hear this from the advocates, these are biological, predetermined situations, and any attempt to alter is problematic. Now, what I did do in the 70s, which I'll confess with no guilt at all, if I was seeing someone who was ambivalent about their sexuality and wanted to explore being successful with a heterosexual partner, whether a man or a woman, I would certainly engage with them and try and help them develop the skills to be able to function. That didn't mean that we've changed their orientation, but it did mean that they were able to pass in a way that was quote unquote considered normal at the time. So I don't regret doing that, but I certainly applaud the changes that have taken place in our culture that allow people to be who they are, and that's where we should be. Anyway, I'm going to stop now and thank you all very much.